This conference will now be recorded.
Good afternoon, everyone. I, on behalf of Shreyas E-Learning Academy, welcome you all in this very unique seminar of Arshah. This is our first session, and the first session will be taken by Dr. Hrishikesh Dilip Nagvekar, sir. Sir has done his BAMS from Mittal Ayurvedic College and his MS from YM Yerla Medical Ayurvedic College and Hospital. He was passed out as a first batch of Anushalya in MS from Yerla Medical College. He is practicing in specialty practices in piles, fissure and fistula at Orthoved Hospital as well as Vedant Ayurvedic Clinic in Dombivli. He carried out more than 1,000 procedures related to piles, fissure, fistula, invasive, non-invasive and panchakarma procedures also. He was honorary consultant at Ayurved Prasarak Mandal Charitable Clinic, Dombivli. Invited as co-chairperson at World Ayurved Congress, Gujarat. And he is also co-author of research paper on the use of nutraceutical in Ayurveda in IJSRP International Research Journal. So with his more of practical, patient-oriented knowledge as well as very good orator and teacher he is, and he is my colleague also. So without wasting much of your time, I request Dr. Hrishikesh Nagvekar sir to deliver his talk on today's topic, that is anorectal disease, clinical anatomy and examination. Sir, please start.
Thank you very much, sir. Thank you, Chintan sir, for this kind introduction. Good afternoon to all the delegates, my dear speakers and everyone who is listening. It is a privilege to be a part of Shreyas E-Learning Academy, and that too in a seminar subject which I work in, that is the anorectal diseases. Every one of us are well versed and well acquainted with these patients, with the patients of proctology, and it gives me immense pleasure to share my knowledge, clinical experience regarding this subject as well today. हम सभी को पता है कि जब ओपीडी में हम सुबह 10 बजे नहा धो के जाते हैं, अच्छा परफ्यूम लगा के बैठते हैं, और अगर पहला पेशेंट आपके पास आता है, आके आपके बाजू में बैठता है और आपको बोलता है कि डॉक्टर 2 दिन हो गए मोशन की जगह से मुझे खून जा रहा है, और पेशेंट आया है इस खुशी को छोड़कर, अब इस पेशेंट का मुझे पीआर एग्जामिनेशन करना पड़ेगा, ये बड़ी दिक्कत की बात हो गई है स्टार्टिंग के ही ओपीडी में। एंड बहुत बार ऐसे होता है कि नाड़ी परीक्षण किया जाता है, पेशेंट की हिस्ट्री ली जाती है और बिना चेक किए बहुत बार पेशेंट को दवाइयां दी जाती है, जिससे पेशेंट ठीक भी हो जाता है। ठीक ये गलत शब्द होगा, जिससे पेशेंट को लाक्षणिक उपशय मिलता है। पेशेंट 1 हफ्ता, 1 महीना, 6 महीने तक ठीक रहता है और वापिस वैसे ही कंप्लेंट लेकर आ जाता है। What I have to say is, when you are dealing with any anorectal condition or per se any condition which involves PR bleeding, the patient has to be thoroughly checked. His PR examination has to be properly done. If required, radiological investigation should always be done, because it could be a patient of a vast stature rather than just a plain case of hemorrhoids, which is generally treated by many physicians. So, anorectal diseases specialty practice involves thorough knowledge of clinical anatomy of that part, the considerable physiology of that part, and a thorough and proper examination so as to reach to a proper diagnosis. बहुत बार पेशेंट खुद डायग्नोसिस लेके ओपीडी में आते हैं कि डॉक्टर मुझे बवासीर हो गया है. दिस इज हिज डायग्नोसिस ओनली, क्योंकि उसने बहुत बार बाहर सुना होता है, कुछ नेबर से उसका डिस्कशन पहले हो जाता है, जिसके बाद वो इस नतीजे तक पहुंचता है कि मुझे आज पीआर ब्लीडिंग हुआ है, मुझे आज मोशन की जगह में इचिंग हुई है, आई हैव गॉट पेन ड्यूरिंग डेफिकेशन, आई हैव स्टार्टेड पासिंग हार्ड स्टूल, and my diagnosis is piles because I have heard about it a lot. तो अर्श या बवासीर या मूलव्याध या पाइल्स या हिमोरॉइड्स ये एक मिसनोमर है. बहुत सारे डायग्नोसिस को ये मास्क कर देता है if the patient is not diagnosed properly or the subjective intervention is not done. So we have to know what the clinical signs are. As we go ahead in our lecture, I will be discussing the clinical anatomy and the examination part. But before that, we'll see what other conditions come up in our OPD, which if we see and do properly, should be managed. ये हो सकता है क्या? Yes, a multi-speciality Ayurvedic clinic can work only in the region of anorectal disorders as well. There is a vast range of treatment protocol, including the conservative management, the panchakarma therapy, बाह्य चिकित्सा जिसके ऊपर हमारे एक स्पीकर बात करने वाले हैं बाद में, and if required, then the invasive management connected to that disorder. So, right from diagnosing the patient to a proper treatment can be done. All conservative and invasive modalities can be done under one roof, and a multi-speciality Ayurvedic clinic can be run if done properly. I'll just now discuss with you all the probable or the common conditions that come up in our OPD, which can be diagnosed and properly treated. This is a case where patient has constipation, no satiety in motions. This is very important. डॉक्टर साहब मुझे मोशन में जाने के बाद ऐसा लगता ही नहीं कि मुझे मोशन बराबर से हो गया है. Only 80% of the stools is evacuated, 20% remain again, after which patient again has the urge to go to the latrine. He again goes, again comes, again goes, and there is no satiety in motions. This is the first sign of this disorder. Feeling of fullness in rectum. There is no mass palpable at the anal verge, and there is no history of PR bleeding. This is generally the starting case of first or to that extent the second degree hemorrhoids. The anorectal ring, which is formed by the puborectalis sling and the levator ani muscles, differentiates the passage of platus and the stool. That is the most important function of it, rather than maintaining continence of stools. नहीं तो हर बार अर्ज जाने के बाद, rather than passing flatus, it could have passed stools every time. So when there is no satiety in motions, there is fullness in rectum, and there is no mass palpable at anal verge, the bulging of hemorrhoid has just started from its root, from the superior hemorrhoidal vein plexus congestion. Then it is a first degree hemorrhoids which generally can't be diagnosed with just palpation or with just plain digital examination of the anal canal. You may feel the rambler-like appearance inside of the mucosa, But in advanced cases, from first to second degree hemorrhoids, you can feel the bulges of the superior hemorrhoidal plexus which are congested. This is the early stage where the patient should be diagnosed, and every time these patients can be treated with a conservative line of treatment. These patients will not require surgery, and these patients can be saved from changing the degree of the hemorrhoids from first to second, second to third, and then go on. So in the second case, you have constipation as discussed, generalized weakness. Patient may have anemia. Patient may not have a history of PR bleeding. There will not be any pain associated with defecation, but there will be a mass felt at anal region during defecation, which the patient has to manually push, or sometimes the mass goes inside after the act of defecation. This is a typical picture of a internal-external hemorrhoid of third to fourth degree. In varying cases of second to third degree hemorrhoids, there may not be a visible frank blood which is passed, but the occult blood can be present, and it could be adjudged with a simple stool routine examination. I have a habit of doing a stool routine examination of every patient who comes to me with a PR bleeding, because that patient can range from a disorder of simple second degree hemorrhoid to a severe rectum as well, or to a lower gastrointestinal bleeding. See, PR bleeding is also a misnomer, because only the passage of blood through rectum or anal canal doesn't contribute to a PR bleeding. A PR bleeding is a bleeding which can take place from the second part of duodenum. Understand this, second part of duodenum below the ligament of Treitz, which is termed as a lower gastrointestinal bleeding, which may cause melena, which may cause PR bleeding. So, proper diagnosis and proper investigation has to be performed in these cases. As you can see in the picture, the congestion is clearly visible. The pile mass has come out of the anal verge. This is a 3 o'clock pile mass. Along with it, if you can see at the 6 o'clock position, there will be an internal hemorrhoid which is starting to come up from a 7 o'clock position as well, along with the skin which is involved with an external hemorrhoid. So this is an internal-external hemorrhoid. Again, can be treated or managed with a conservative line of treatment. But for this, you have to do an inspection. Sudden pain at anal verge, difficulty in sitting, पेन ड्यूरिंग डेफिकेशन, हिस्ट्री ऑफ ट्रॉमा एकदम टिपिकल केस है जिसमें 2 या 4 दिन की ही हिस्ट्री रहती है. पेशेंट आता है, आप उसको बोलते हैं बैठो, पेशेंट बैठने से इनकार करता है. वो बोलता है डॉक्टर मुझे बहुत ज्यादा पेन 3 दिन से हो रहा है. दिस कैन मिमिक अ केस ऑफ पेरियनल एब्सेस एज वेल, बट इफ नॉट सीन और नॉट डन पीआर, then you will not understand this, and फिर हम एंटीबायोटिक देके उसको मैनेज करने की कोशिश करते हैं. लेकिन a typical history of trauma or anal verge, it could be a traveling history. The patient has just traveled through a uneven road and this condition has come up, or the patient has a history of pulling up large objects or heavy dumbbells in his gym and this condition has come up. This is a typical case of piles, but not a simple piles, but a thrombosed hemorrhoid. A thrombosed hemorrhoid is nothing but a second to third degree hemorrhoid which comes up and the plexus behind it gets twisted so as to cause obstruction, and the blood clot is formed in its distal end, which could be visible, which is very painful on touch, which is very painful during sitting, and this also can be properly managed with a conservative line of treatment. बाह्य चिकित्सा में अवगाह से लेके बहुत सारे अच्छे अच्छे नुस्खे हैं जिससे ये थ्रोम्बोस हिमोरॉइड, अगर आप पहले 5 दिन में पेशेंट आपके पास आया है with this history, then the patient can be perfectly managed with a therapeutic line of treatment, with a conservative line of management. No history of bleeding PR, no pain during defecation, no constipation, no hard stool. There is only history of mass coming out during defecation. This also resembles as Ursha, but it could be a plain mucosal prolapse. This is not a rectal prolapse. This could be a plain mucosal prolapse which can come down, which again goes back after the act of defecation, and it is not associated with any bleeding or pain during defecation. This is a condition which should be treated aptly. In majority of the cases, this condition has to be managed with an invasive line of treatment rather than a conservative treatment. But there are many treatment protocols related to the Brownsha which can be applied to this, and this case can be misdiagnosed and treated as piles. But for this, a proper digital examination has to be done. See from where the fold is coming from the anorectal ring with a digital examination or a proctoscopy, and it could be made out that this is a plain mucosal. See, there is no skin involved with this, only a plain mucosa of the anal wall has come down due to the laxity of musculatures and sphincters, which we will discuss further. There is no pain during defecation, feeling of fullness in the anal canal, no history of PR bleeding, feeling of mass coming out of the anal verge post defecation and constipation. This could be, the picture shows it could be a polyp. This polyp can't go with a conservative line of treatment. It is advisable that this polyp should not be tied with a Kshar Sutra as well. This can be tied in a transfixation suture can be done, which is a normal surgery of polypectomy, which we do in our cases. This sometimes comes up, but during the process of doing the operation, it can bleed profusely. So this is a other condition which can come up like Ursha, but it is not. No history of PR bleeding, no painful defecation, no feeling of mass at anal verge. There is a history of boil over perianal region and soiling of inner clothes. The picture says it. This is a Bagandhar Pitika, which can be developed into a full-fledged tract of Bagandhara, which has to be diagnosed and treated accordingly. So this is a fistula in ano, very common and very easy to diagnose from inspection, but it has to be thoroughly diagnosed internally as well to see where the tracts are formed. There is no history of PR bleeding, or PR bleeding may be occasional. There is no mass at anal verge. Anemia, weight loss, increased constipation, very well missed. Hence, a stool routine is always advised with a PR bleeding. The proper history has to be taken, and this could be a carcinoma rectum as well. Sometimes when the carcinoma rectum advances into the anal canal, a cauliflower-like growth or an uneven hard growth could be felt into the anal canal, and this you can diagnose with proper scopy of the part, and then if required MRI to see its secondary infiltration. So this is a case which is generally treated as PR bleeding of hemorrhoids without any inspection, and you could land up missing the diagnosis and putting the patient into a lot of trauma afterwards. Post-operative fistulectomy wound, there is delayed healing in granulation, no active pulse discharge, no pain, no signs of active inflammation. I am very privileged if someone shares this case during the course. We had 10 to 15 cases now of this clinical condition where a fistula was diagnosed, Kshar Sutra management was done, but post-operatively after that, there was no healing granulation of the Kshar Sutra tissue. Of the healthy tissue was not formed. The Kshar Sutra kept changing. The cut was not there. The cutting and healing process had stopped. And in these cases, surprisingly, there was a secondary focus of tuberculosis. And when the treatment of tuberculosis was started, the tract started healing properly. Don't believe, but 10 to 15 cases we have formed this with a history of TB or a secondary focus of tuberculosis, after which a proper AKT was started and the fistula wound started healing. So this is one other case which can come up in your clinical practice. Now we move on to the surgical anatomy, which is the topic of ours today. I just wanted to brief the different type of arshas which are diagnosed in the 7 cases and the diagnosis is missed. Hence the thorough examination and hence those cases were taken. So the anal canal, to sum up very easily, is a 3.75 centimeter tubular structure, a luminal structure. It has typical mucosal folds. If you see in the Darshan Pariksha of anal canal, the first thing that you will see is the change of color of the mucosa. It starts from faded bluish pinkish color, then a proper pink color, and then a red color, which continues with the mucosa of the rectum then. Why this is important? Because when we do a diagnosis and do an invasive management, we have to perfectly adjudge the dentate and pectinate line, because it carries a vast importance when we do an invasive management here. So the mucosal fold, as we have seen in Ayurveda as well, the anal canal is consisting of 3 folds. 3 वलियां वहां पे रहती है, जिसको प्रवाहिनी, संवरणी और विसर्जिनी ऐसे नाम दिए गए हैं. एक मोशन को होल्ड करने का काम करता है, एक उसको एनल कनाल को डिफ्लेट करने का काम करता है और एक मोशन को बाहर धकेलने का काम करता है. ऐसे प्रवाहिनी, संवरणी और विसर्जिनी पेशियां या वलियां एनल कनाल में होती है, जो 4.5 अंगुल का एनल कनाल है, जिसको 1.5 अंगुल के ऊपर यह वलिया होती है जो अपना कार्य करती है, which is related to the act of defecation, where the defecation reflex takes place and the internal sphincter is relaxed, the external sphincter is relaxed, and the anorectal ring is relaxed, so as to pass these stools that are collected in the rectum and passed out of the anal canal. So these folds are important. Dentate and pectinate line are arbitrary lines which can be seen or which can be felt or which can be judged from the proper examination of the anal canal. Below the dentate line, where the fissure lies, is supplied by a huge network of nerves, specifically the pudendal nerve, and this causes tremendous amount of pain when any anomaly is situated below the dentate line towards the anal verge. Above the dentate line lies the pectinate line, where above the pectinate line lies the glands, the anal glands, which is the source of infection of fistula. According to the cryptoglandular theory, which is heard or said about the formation of fistula, the stool particles sometimes embed in these anal glands. The microorganisms or the bacterial infusion takes place in these anal glands, and these anal glands drain into the anal crypts, and from anal crypts these glands drain into the 4 specific spaces besides or covering the or in the periphery of the anal canal, where there is pus formation, where there is abscess formation, and these abscesses then drain into the anal canal through transsphincteric, intersphincteric tracts, submucosal tracts, perianal tracts, so as to create fistulae. So in the surgical anatomy, it is very important to know the dentate line, whether the anomaly lies below the dentate line or above the dentate line. Specifically, fissures, small polyps, hypertrophied papillae, or the external hemorrhoids, skin tags are below the dentate line, which are generally painful, and above the dentate line lie the polyps, the internal hemorrhoids, the tracts or openings of the fistulae, which are generally painless but are associated with a amount of PR bleeding with them. Anal glands can be seen in the surgical anatomy. When you do dissection, you can see those glands where the infection lies, and these spaces are nothing but supralevator space, which I will be showing in the diagram ahead. Supralevator space, ischiorectal fossa, submucosal space, and a perianal space, or the intersphincteric space, where the drain of all these abscesses come so as to form internal and external openings of the fistula tract. So anal canal is basically the last part of large intestine: ascending colon, transverse colon, descending colon, sigmoid colon, rectum, anorectal ring, and then anal canal. Anal canal generally is not straight whenever you are standing in a supine position. So the anorectal angle which is created, which needs to be deflected during the act of defecation, or it has to become obtuse so as the rectum and the anal canal come in a straight line so as the smooth passage of stools can be done. Hence, there is a typical position which the Indian position, as it said, the Indian toilet is the proper squatting position where the rectum and the anal canal come into the straight line so as the stools are evacuated properly. The English toilet is avoided, or there can be a provision made to take a stool in front and place the legs on it so as to maintain a more obtuse angle in the anal canal, and the passage of stools is done. So the position of the anal canal is not straight. It has to be maintained that way during the act of defecation. The relations with adjacent organs is very important. When you are treating any case of anorectal disorder, you have to know the clock, the anorectal clock. The patient be in any position. It can be a lithotomy position, it can be a left lateral position, it can be a jackknife position, it can be a Fowler position, it can be a dorsal position. The anorectal clock never changes. What is this clock? Anorectal clock is a clock when you see the patient imagine the patient in a lithotomy position. The 12 o'clock position resembles to the position pointing towards the perineum or scrotum in males, and the position pointing to perineum and vaginal opening in females. The 6 o'clock position always points to the sacral crest or the tailbone. The left hand position, the position where the clock points, or the 3 o'clock position, is generally associated with the left hand of the patient, and the 9 o'clock position is associated with the right hand of the patient. When you sit in front, the 9 o'clock, the 3 o'clock position will be your right hand, and the 3 o'clock position will be your right hand, and the 9 o'clock position will be your left hand. This is anorectal clock which should be by-hearted and seen while diagnosing any patient of the anorectal disorder or disease concerned. Because the position of superior hemorrhoidal veins, which is a 3 o'clock, 7 o'clock and 11 o'clock position, where generally the internal external hemorrhoids are formed, and these are called as the primary hemorrhoids or primary ursha. And in between clock position hemorrhoids, where the external tags develop, say 2, 5 and 11, are generally associated with the external hemorrhoids. Plus, when we are doing a operative related to an anorectal canal or the anal canal, the adjacent organs, the above organs are the urinary bladder, the vaginal wall in females, and the pouch of Douglas. When you are doing a operative on the 6 o'clock position, you should remember that the tailbone and the sacral end is very nearer to it. In the 9 o'clock and 3 o'clock position, there is a gluteal muscle. There is a ischiorectal fossa on both sides, which contains the sciatic nerve. So all these things you have to keep in mind while operating on the anorectal field. Arterial supply and venous supply is same. Superior rectal arteries supply to the anorectal, the anal canal, and the inferior hemorrhoidal veins and the superior hemorrhoidal veins drain from the anal canal to the inferior mesenteric plexus and then go on. This is also very important while operating. Nerves, as I said, the pelvic nerve generally circulates over the rectum and transmits various nerves, of which the inferior pudendal nerve and the superior pudendal nerve generally supply to the anal canal. And when you are diagnosing patients of a sphincter control loss, incontinence, then these nerves have to be adjusted whether the proper functioning of the nerve is taking place or not. So this is the basic surgical anatomy of the patient, of any human being. Anal canal musculature. This is very important. Imagine the anal canal in front of you kept parallel to your eyesight. Above the anorectal canal, of the outside the mucosa of the anal canal, lies the anorectal skin. After that, there is circular passage of the internal sphincter. Then there is a space. Then there is a longitudinal muscle, again circularly arranged. Then again a circular space is there, and then there is again a sphincter is there called the external ani sphincter. So the anal canal, then internal sphincter, then a space, then a longitudinal muscle, then a space, then a external ani sphincter. This is the positions where the intersphincteric spaces drain into the anal canal through fistulae. These contribute to the continence of the anal canal as well. There should be proper relaxation of internal and longitudinal muscle, internal sphincter, longitudinal muscle, and anorectal ring. And concomitantly, there will be relaxation of external sphincter when the act of defecation is taking place. So, during examination, you have to examine all these sphincters as well. When you do a proper digital examination, you can feel the tone of the anal canal or the anal musculature. You can feel the tone of the anorectal ring, which is very important, whether it is lax, whether it is hard, whether it is proper, and the anatomical spaces which I discussed earlier. If you can see in the diagram, these are the spaces where the abscesses are formed between the sphincters. The tracts roll in. If you can see, the tracts roll in from these intersphincteric spaces, and these spaces, see, this is the ischiorectal fistula, where the focus is in the ischiorectal space. The abscess drains and comes out through an external opening outside. If you can see here, this is the pelvirectal or supralevator space. This is a puborectal muscle. And this is the ischiorectal space. This is the submucous space where many of the fistulae develop and come out from the anal canal. See, this is the position. This is the external ani sphincter. This is the internal ani sphincter. These are the anal columns, or where the anal glands are situated. This is the dentate line, pectinate line, and this is the anal verge. This is circularly attached. This is a front picture. So when you see a three-dimensional picture, this is a circular space. The internal sphincter, then space, longitudinal muscle, then space, and then external ani sphincter, which contribute to the continence. What are the clinical features that are associated with ARSH? Are generally bleeding, discharge. It could be a pus discharge, purulent discharge, mucus discharge, or a blood discharge. Pain is generally associated with conditions of fissures, thrombosed hemorrhoids, or active abscesses. Abnormality of bowel habit is a very important feature. मलावस्तंभ से ही शुरुआत होती है anorectal disorders की, because this is a lifestyle disorders. There could be prolapse of mucosa or a complete rectal prolapse. There could be pruritus. There could be itching around the anal canal, which contribute to many fungal infections or condylomata of the anal canal as well. And there is a specific past history of the patient having an anorectal disorder, say 5 years back, and now it has transuded into some other anomaly as well. So these are the clinical features when the patient should run to the doctor, and the doctor should examine the anal canal so as to find out the proper diagnosis. Now, how to examine? हमारे आयुर्वेद में बताया गया है दर्शन, स्पर्शन, प्रश्न परीक्षा. सेम वे में यहाँ पे हम जाते हैं. सबसे इंपॉर्टेंट जब भी आप पेशेंट को देखना चाहते हैं तो every time you should have one assistant. Specifically when there is a female case, you should have a female assistant with you while checking a anorectal canal or a anal canal. The patient can lie in many positions. It could be a left lateral position, it could be a knee elbow position, it could be a lithotomy position, it could be a dorsal position. Every position carries its significance. If the patient is comfortable, if the patient is not bedridden, if the patient can sit, stand, walk, this is the most ideal position, where the left lateral position, where the patient is asked to flex his knees. I specifically asked to flex both knees towards the chest and lie on the left lateral side, and the PR examination can be performed. मेरे गाइड हमेशा मुझे बताते थे कि जब आपकी उंगली को आंखें आना चालू हो जाएंगी तब आप एक अच्छे anorectal सर्जन बन सकते हो. The more number of times you do a digital examination with your index finger, the more you will know what lies inside the anal canal, and more precision you will get while treating the patients or diagnosing the diseases of the anal canal. This is a specific position, many of the time used in OPDs for diagnosing second degree, third degree, fourth degree hemorrhoids, to see many inspective points which will come further as well. This is a specific position where you need to see the anal canal slanted downwards so as to have a deep inspection of the rectal wall. This position is generally used. Lithotomy position is used in many cases of Charolais, in many cases of diagnosing many treatments. Is a specific position to do a proctological investigation. Many cases where a video proctoscope is passed through the anal canal and the rectum towards the sigmoid colon. In many cases where you have to do probing, a probing can't be done in a lateral position or the knee elbow position. The probing of the fistula tract is generally done in a lithotomy position, which gives access to the doctor to perform the proper probing so as to access the tracts. Dorsal position is also simple position where the patient is bedridden, paralyzed, may not be able to move, a senile patient, and you can do a PR examination in a dorsal position as well. What we have to do in inspection? आपको क्या देखना है anal canal में? So when you tell the patient to unclothe him, the first thing that you have to see without doing a PR examination is to see the local redness, which can be very common in many cases of abscesses, fungal infections, and skin disorders of the anal canal or the anal verge. There could be swellings, it could be a third degree hemorrhoid, it could be polyp, it could be a swelling of abscess, it could be a swelling of sinuses which could be seen. The obvious fistula's openings, the external openings of the fistula can be inspected or can be seen in many cases during inspection. There could be a pilonidal sinus which could be missed if you have not selected the proper position of the patient while inspecting. So pilonidal sinus could be properly inspected and judged and then diagnosed. There could be growths outside the anal verge. There could be, I have seen many cases now of unusual sites of lipoma, cyst in the anal canal as well, or besides the anal verge as well, which could be diagnosed with a proper inspection as well. There could be external skin tags, external piles, which can be associated and can be seen. So this vast number of cases you can just diagnose by inspecting the anal verge. This is a pilonidal sinus where the sinus openings could be clearly seen. These are 4th-degree hemorrhoids. See, all the plexuses are very much seen. The plexus you can see. The skin component is also seen, and this can be diagnosed with a proper examination. As you can see, the anal canal is stretched so as to see this. There could be fistula openings. There could be skin tags, multiple skin tags which are associated with many conditions. There could be fungal infections or condylomata of the anal canal as well, which can be just seen with a proper darshan pariksha. If we see the grading of hemorrhoids and see after inspection as well, there is no protrusion of hemorrhoids in stage 1. There is protrusion of hemorrhoids in stage 2, but it has not crossed the anal verge. That is, you don't have to push the mucosa out of the anal verge. In the 3rd stage, there is protruding of the hemorrhoids, possibly to push back it manually. Sometimes it gets pushed automatically inside the anal canal, but specifically in the 3rd-degree hemorrhoids, the anal verge has to be constricted and it has to be pushed with a finger manually inside so that the mass doesn't come out again. But in the 4th-degree hemorrhoid, the mass can be easily seen protruding out of the anal canal, and this can be pushed inside, but it will come back again to its initial position when you are sitting, squatting, or going for motion. Again, the patient goes for motion again. So in stage 1, there is no protrusion, not associated with a digital examination, can't be judged. In the 2nd position, it can be judged with a proper PR examination, and there is no protrusion outside the anal verge. In the 3rd part, the protrusion is there but can be manually reduced, and in the 4th part, the manual reduction is not possible, or if possible, it will come back again. In the inspection part, you have to see this rule. You have to follow these rules as well, which is a common rule in many conditions of fistula in anal. But believe me, as the practice is going on, or the senior practitioners might tell you as well, that in majority of the cases that we see now, the Gursal's rule may not be followed. Still, it gives you a guideline after inspection, after just inspection, where the external opening of the fistula lies and where the tract could go inside the anal canal. So what the Gursal's rule says, it is basically, it is not associated with piles. It is generally associated with fistula and the external openings of fistula only. The Gursal's rule says that if you draw an imaginary circle 1.5 centimeter in circumference outside the anal verge, all the openings inside the circle anteriorly to the transverse anal line, you can see the transverse anal line, which is the middle line drawn from the anal canal, the openings which lie inside 1.5 centimeters will drain directly into the 12 o'clock position of the anorectal clock. But if the opening lie outside 1.5 centimeters of the anal, यानी बगंदर पिटिका अगर 1.5 सेंटीमीटर के अंदर है तो उसका ट्रैक लीनियर होता है. It will not be a bifurcating track and it will drain in the 12 o'clock position only. But if it lies outside the 1.5 centimeter, then it will traverse to have a track in the 6 o'clock position. Now, below the transverse line, the external opening could be anywhere. It could be inside the circle or outside the circle. It generally drains into the intersphincteric space of the 6 o'clock position only. So this can be adjusted during inspection, and you could have a rough knowledge of where the fistula tract can go. Of course, in many advanced cases, MRI can only show the sphincteric variation of the fistula that is created rather than a simple Kursal swoop. After inspection, after seeing all the anomalies like this, what can be seen in palpation? And this is very important when you palpate an anal canal or you do a digital examination of the anal canal. The first and foremost thing you can palpate outside the anal verge is a typical swelling. It could be boggy, it could be hard as in cases of the Amavastha of many Vidradis. It could be boggy in cases of lipoma, cyst or any other swellings of the anal canal. It could be hard, it could be a hard mass impending outside the anal verge but has come out outside. I have seen many cases of CA rectum who transfers down to the anal canal, make the hard opening and may come outside the anal verge as well. These swellings should not be ignored. There could be a typical swelling after palpation of the hemorrhoid which is soft, very soft, and which could be manually shifted inside. In the thrombosed hemorrhoid, as we discussed in case number 3, the swelling is very hard. It resembles a blood clot and which is not manually sent inside. So the swelling could be of any type as discussed, but with a proper palpation you can lead to a proper diagnosis. There could be a tenderness in cases of abscess, thrombosed hemorrhoids or masses surrounding the anal verge. There could be tenderness when you just start your PR and there is a fissure in the intersphincteric space, which could be a very painful condition. And I would like to say this, that if the PR is painful, if the anal verge is painful, and in the starting course of PR, the digital examination, if pain is tremendous, the proctoscopic investigation is contraindicated. It should never be done. The patient can go into a shock, a hypovolemic shock, a neurogenic shock during the course of proctoscopic examination done, even if the PR was very painful. So the rule is you should always give proper treatment to the patient first, subside his pain, and then do a proctological investigation if required. Tunnel formation. This is a very important thing which should be palpated if you are treating a case of fistula in ano. आपको पता है, अगर आप इमेजिन करोगे एक टनल जिसको 2 एंड्स होते हैं, एक एंड से गाड़ी अंदर आती है, दूसरे एंड से गाड़ी बाहर जाती है, there is an entry point, there is an exit point, and there is a wall surrounding this tunnel. This is nothing but common fistula tract which can be adjusted. There is a proper tunnel formation which is seen. There is an external opening, there is an internal opening, and you can palpate with your thumb or 2 fingers, index finger and thumb, from the internal opening to the external opening. You can catch the tract. You will feel it as a tunnel, and you could be easily diagnosing a simple linear fistula with it. Of course, if there will be bifurcations, you have to go for a radiological investigation, but a tunnel formation could give you a guide whether the fistula tract is formed or not. Fluctuation is common in many cases of Amavastha, Pachamanavastha, of Vidradi, as I said, many cases of swellings of the anal canal as well. So this palpation has to be done properly after inspection to diagnose many conditions. Now, what could be seen inside in the anal canal when you do a digital examination or proctoscopic examination? The digital examination, why I am pointing again digital, because PR examination is not digital examination. Digital examination is something which you do with your index finger, and we term it as a PR examination. But PR examination as a PS examination, per speculum examination, is a examination which is done to see the anal canal and rectum as well. So basically, proctoscopic examination can be termed as a PR examination, or any other camera video proctoscope which is passed to see the rectum, to see the wall of the rectum or a head. It could be a PR examination. So in a digital examination of the anal canal, where the index finger is first kept perpendicular to the anal canal and then slowly inserted parallel to the anal canal, the first and foremost thing that you should see is spasm. There is a grade 1, 2, 3, 4 spasm which comes up with your clinical practice. A fissure will have a 3rd-degree spasm. The patient will not allow you to do a digital examination. That kind of spasm also develops in chronic fissure. If you have seen patients of chronic, say 6 months, 1 year, 2 years, the patient is coming back again and again. The anal canal gets constricted. The internal sphincters get fibrosed so as to create a very less curvature of the anal verge. And there is a typical anal spasm which is associated. Spasm is nothing but the contracture of the sphincters and muscles surrounding the anal canal. And this spasm can be relieved beautifully, not only with Lord's anal dilatation, but with many Ayurvedic techniques as well. So there could be spasm which should be judged. There could be swellings as polyps, hypertrophied papillae, internal hemorrhoids, or the cauliflower-like growths common with the carcinoma part. There could be papillae, there could be growths. The tone of the sphincter should be judged with a digital examination. There could be dimples felt, that is the internal openings of the fistulae, which can be felt with a digital examination of the anal canal. These parts, this digital examination forms a very important part of everyone who practices the anorectal part, or who doesn't practice but a case comes up, you have to do this. So there are 3 parts which you can see in a rectal digital examination or the proctoscopic examination: within the lumen of the anal canal, in the wall of the anal canal, and outside the wall of the anal canal. See, there is, why I am taking examination is because there is not a single case of Ursha only in the anal canal. Within the lumen, you can judge the intussusception also sometimes. The cauliflower-like growth which contributes to carcinoma, the internal openings of fistula, fibrosis, post-operative fibrosis can easily be diagnosed with a proper rectal digital examination, and this should be diagnosed before doing a second operative, because the anatomy of the anal canal is altered in the first operative, and you may lead to reveal this fibrosis of the sphincters, which is generally seen in second or third operatives as well. And the tone, which I just discussed. In the wall could be thrombosed piles, many ulcers which you could form, ulcerative colitis, Crohn's disease also fulfill many of the cases of PR bleeding which should not be missed. Internal openings of fistula, anorectal ring, polypus, stricture. As we discussed, the stricture is also a very beautiful case which should be diagnosed, and this stricture generally doesn't relieve with a conservative management and may require its splitting procedure. And the carcinoma of the rectum, the mass could be filled. Posteriorly, when you see where this sacrum and coccyx lie, there could be a sacral and coccyx abnormality. You can also diagnose BPH, that is benign prostatic hyperplasia. With this, you could palpate the median lobes, the hypertrophied median lobe, the lateral lobes of the prostate as well. There could be a sacral and coccygeal fracture, which can be diagnosed with a proper PR examination as well. There will be pain associated with it. Coccydynia can be one feature which could be presented with a PR examination. Sacrococcygeal teratoma and postanal dermoid are also cases which could be adjudged with a proper rectal digital examination, and which could be felt posteriorly. As anteriorly I said prostate in males, posteriorly these anomalies could be judged, which are generally missed. In the bimanual examination, when you palpate from below the umbilicus and the rectal examination is done, the annular carcinoma of the rectum, that is the lymph node enlargement, can be seen. In many of the cases, you can palpate the mass as well in bimanual examination of the anal canal. In special investigations, proctoscopy, transrectal sonography, fistulogram, sigmoidoscopy, colonoscopy, MRI pelvis, anal manometry, and there is a range of radiological investigations which my friend, dear speaker, Dr. Sunil Dhavre sir, will take in his lecture. So I will not go into the details. But believe me, the world has changed. Believe me, the rational use of all these investigations has to be done in the diagnosis of anorectal disorders. Dear all delegates, don't consider the anal canal as a simple space. It could be a 3.75 centimeter space, but there are a vast number of anomalies associated with it, vast number of anomalies which present as complaints associated with anal canal and which could be misdiagnosed. So, a proper digital examination, then if required proctoscopic examination, then if required sonography. In cases of fistulas, you have to do fistulogram, MRI pelvis, MRI perineum, which also forms a proper helping hand in diagnosing the cases and then treating them successfully. So, your hand should not stop while writing any investigation just because it is very costly. It could benefit the patient with a proper diagnosis and it could not lead to first, second, third, fourth operatives of the patient which are generally done because of the misdiagnosis or a blind procedure is done in many of the cases. So, in ARSHA also, this investigation should be done if you are suspecting something other than ARSHA and related anomalies can be adjudged. These are the tools which are used in the examination of anal canal. The first thing that a MS student will do or will have in his OPD will be a proctoscope. Now ARSHA यंत्र से लेके जो एक 6 सेंटीमीटर का यंत्र था जिसको एक आगे छिद्र था जिसको हम प्लेस करके अंदर से इंटरनल हिमोरॉइड्स या प्रवृत्त अर्श को हम जानते थे, वो अभी एक एडवांस टूल बन चुका है. There are vast number of proctoscope now available right from a rigid proctoscope to a soft malleable proctoscope which are generally used while during laser surgeries as well. So a anoscope is generally of 10 centimeters, proctoscope is generally of 13 centimeters and a rectoscope is generally of 25 centimeters. There is a video proctoscope as well or the self-illuminating proctoscope as well. There is a light inside the proctoscope, there is camera inside the proctoscope which could illuminate the anal canal while viewing. We are used to just generally using the metal proctoscope with a vision, the light man will show a light from inside which is changed now. But I urge every delegate who is listening this seminar to buy a proctoscope, keep it in their OPD, do a digital examination, and if required, you have to do the proctoscopic examination. Get yourself trained from any person who is trained in this field and start doing these procedures because it could lead to many diagnoses and you only will be happy by using this and diagnosing many majors. Inside the lumen, in the ball, outside the ball, these anomalies could be judged with these simple instruments. Advanced modalities include this video proctoscope, laser scopes, sigmoidoscopes, colonoscopes, which are now very well used with a normal minimal invasive anesthesia or to an extent in some OPDs, minimal procedures can be done with these scopes as well. Therapeutically also, these scopes are now very much useful while doing a ligation of a high anal hemorrhoid, doing a band ligation of any ulcer which is associated with Crohn's or this can be done as well as advanced modalities in diagnosing the anorectal disorders. MRI pelvis and perineum also forms a very important tool in diagnosing the fistula gradation, the sinuses, growths and secondary infiltrations of the anal canal if it is related to any ischial bone, to the sacral and coccygeal bones, to the prostate, to the bladder or anything which lies outside the anal canal. many of the times, many practitioners don't do this and then fall to a recurrence of fistula. So it is very advisable if you are not sure whether the track is linear, single, simple, low anal, always do a MRI pelvis and perineum, which could lead to a proper differentiation of the tract and the intersphincteric or the sphincteric course of the fistula tracts, which can be properly managed with the necessary form of intervention. So, what we saw today was the normal anatomy of the anal canal, what all things that the anal canal can give you or the anal canal can be presented, that present with difficult anomalies, not only ulcer, not only just piles, but various diseases which can be properly diagnosed with a digital examination, with a per rectal examination, with a normal proctoscopic examination, with a sonography, with a colonoscopy, and if required, with an MRI. Inspection, palpation, auscultation is not done in this part, but darshan, sparshan, and proper prashna pariksha, proper history could lead to a proper diagnosis of the anomaly of the anal canal. Anal manometry is something which should be properly used as well, not only in the cases of hemorrhoids post-operatively. When the hemorrhoids come up again, you should always see whether it is a mucosal bulge or the hemorrhoid and see the sphincteric control through the anal manometry which is done, and the tone of the sphincters, the tone of the anorectal ring can be adjusted, and then specific measures can be used to prevent them from causing any other anomaly related to the anal canal. This should be vividly explained by the speaker who is going to take the radiological and pathological investigations to the anal canal. But remember this, the first thing that you have to do without doing any how I'll do. No, if the patient comes, you have to do the digital examination, the rectal examination, and form a diagnosis, and then treat it accordingly. The course of diagnosis and the management will become in the upcoming lectures. Thank you very much for listening to this session. Shaurya Mashukriya Shastra Taikshna Asveda Vepatu Asammohasya Vaidyasya Shastra Karmani Shasyate, वही एक अच्छा एनोरेक्टल सर्जन बन सकता है जिसके पास शौर्य है, आशुक्रिया है, जो फास्ट डिसीजंस ले सके, जिसके पास शस्त्र तीक्ष्ण यानी सब इंस्ट्रूमेंट्स अवेलेबल है, जो बिल्कुल घबराता नहीं ये सब प्रोसीजर्स और डायग्नोस्टिक टूल्स यूज करते समय, वही वैद्य एक अच्छा शस्त्र कर्म करने वाला वैद्य बन सकता है, एक शल्यकर्ता बन सकता है. प्रधान हस्तमेव प्रधानतमम यंत्रम, स्टार्ट यूजिंग इट. आपके हाथ पे जो इंडेक्स फिंगर है, जैसे मैंने गाइड हमेशा बोलते थे कि लेट योर फिंगर गेट द आईज टू सी what lies inside the anal canal, do 1000 PR examinations, and then do a proper, come to just a diagnosis. Treatment part is very easy. Proper diagnosis can only save the patient from grave consequences. Thank you very much. Thank you for patient listening. Thank you all the speakers and the organizing team of Shreyas E-Learning Academy. Thank you again for giving me this opportunity to present my topic in this Arsha seminar. Thank you very much.
Hello.
Yes, sir.
Thank you, Dr. Rushikesh. It was nice session. If anyone has doubt, please put it in chat box. think lecture was self-explanatory, so no one has doubt in this first session. So we will meet you tomorrow for another session of this Arsha seminar and with another topic. So thank you very much for all the delegates, and thank you very much Dr. Rushikesh for nice and informative session. Thank you.
Thank you, sir.
Chat box is there.
That's while injecting LA, local anesthesia, which anatomical precautions should be taken? Sir, it is very important to know and which block you are giving. Generally, the local anesthesia which is giving during the procedures of anorectal cases, the lithotomy is the preferred position. You have to know the anorectal clock. The only thing that you should do, that while doing, the patient has to be given a pain relievant first, and then only a proper local anesthesia can be infiltrated. You have to use the proper needle. Generally, a 26 number long needle is used during injecting a local anesthetic while doing a local procedure of the anal canal. A proper pudendal block can be given by judging the ischial spine and the tuberosity, and you should know all the clock positions as well, and then a local anesthesia can be properly given. I don't have a video right now in this computer, but I will share it with you if the organizers allow me in the coming sessions. There are many procedures which are limited to a proper pudendal block as well. See, there are many cases where skin tags. I specifically don't do procedures in a local anesthesia. I do it in a caudal block or a short spinal block, and then you can give a local anesthesia or a local field block that we see outside the anal verge, only to secure the pain of the patient post-operatively. In the first case, as we have asked, in some conditions, a proper pudendal block can allow the physician or the surgeon to do a normal procedures of skin tags or the hemorrhoids, as you say. But in many cases of fistula, where the tracts are high anal, a pudendal block may not be sufficient. Just a pudendal block will not be sufficient to do all the procedures. Or if to that extent, if the block fails, because you never know whether the block is proper or not, or self-sustaining or not, or to an extent what time it would hold, the patient may experience a lot of amount of pain associated with it afterwards. Is proctoscopy indicated in fistula in ano? Yes, why not? Proctoscopy is indicated in fistula in ano. Fistula as such, if not in its active phase, it is a painless condition. Only the discharge is there. You could be able to see the sphincters or the opening through a proctoscope. You could see the abscess drain through the internal opening while doing a proctoscopic examination. Proctoscopy is generally not done in acute cases of fissure in ano, but it could be done in fistula in ano. But rather than that, basically a MRI or a fistulogram helps in cases of fistula.
I think we should end this session here. and we will meet tomorrow. Thank you very much.
देखने अब लड़की टिक टिक आवाज आता है डीप लेवल एक काम का ट्रेनिंग करा